Hello, everyone. My name is Sherif Shazly, and I am pleased and excited to present our work on endometrial cancer individualized scoring system. Um, so, as you know, endometrial cancer is the most common gynecological cancer in developed countries, and there have been 420,000 new cases globally recorded in 2022. And of course, Europe carries a significant share of this burden, particularly in countries like the UK. So, although early stage endometrial cancer has good outcomes, the recurrence and the progression are still a challenge. As we know, the FIGO staging system has been widely used, which is actually relied in the most part on anatomical features, and it doesn't necessarily cover all the prognostic factors related to endometrial cancer. So, to overcome these limitations, we have created the endometrial cancer individualized scoring system, which has been developed using machine learning to integrate clinical, pathological, and treatment variables for more accurate and personalized survival prediction. So, the study aims to externally validate the predictive accuracy of endometrial cancer individualized scoring system, particularly for the assessment of a 5-year disease-specific survival, and to compare that to the performance of the VIGO staging. So, to achieve that, a retrospective multi-center cohort study was conducted across 5 European centers, including centers from the UK, Australia, Portugal, Spain, and Turkey, in order to validate the endometrial cancer individualized scoring system model using diverse patient populations. So, to select patients for this study, we have included all women who were histologically confirmed to have endometrial cancer between July 2017 and June 2019, and who completed the treatment within the same oncology centers and had a minimum of 5 years of follow-up. We excluded women with incomplete data, women who did not have any surgical treatment, or those who were lost to follow-up. So, in order to collect data for this study, we created a standardized data collection sheet and used medical records of those patients in order to be able to fill the variables required to calculate the endometrial cancer individualized scoring system, which includes two types of scoring. It's score 1, which is a preoperative score, and score 2, which includes score 1 and the variables related to the treatment plan. So the score 1 includes the demographics, comorbidities, imaging, histology, and VIGO staging. And score 2 includes surgical details and adjuvant therapy details as well. We use the endometrial cancer individualized scoring system calculator, which is available in the website as an open application for everyone, in order to calculate the scores of those patients and compare them to the actual outcome in terms of the 5-year disease-specific survival. So as we highlighted, the 5-year disease-specific survival was our primary outcome. We compare the performance of the calculator, the new calculator created by machine learning technology, to the performance of the standard VIGO staging. So for the sample size, a minimum of 47 patients were required based on the expected area under the curve of 0.87, which is the area under the curve that was revealed by the original study that created the endometrial cancer individualized scoring system. We have initially collected data from 692 patients, but only 186 were eligible, and they were sufficient to cover for the sample size that we need. For statistical analysis, we used the ROC curves in order to assess the predictive performance of the target score system. So as a result, as we mentioned, we were able to collect data on 186 patients who met our eligibility criteria and completed a 5-year follow-up. The mean age of this population was 64. The majority were white European, around 63%. Those patients have chronic hypertension in 49% of patients, and type 2 diabetes in 25% of patients as the most common comorbidities. So in terms of histology, 25% of the tumors were the non-endometrioid subtype, meaning that 75 were the most common endometrioid subtype. Lymph space invasion was noted in 41% of patients. 37% were grade 1, 29 were grade 2, and 34 were grade 3. Most patients underwent simple hysterectomy, around 93%. Omentectomy was performed in 24%. Lymphadenectomy was omitted in 52%, and 22% received comprehensive pelvic and para-aortic dissection. Adjuvant therapies include brachytherapy in 35% and external beam radiotherapy in 34%. So in terms of distribution of the endometrial cancer individualized scoring system, we found obviously that the distribution of the scoring of our patients was of course inversely related to the Vigo staging, meaning that the higher the staging, the lower the score, which makes a lot of sense. So the median score, specifically score 1, ranged from 94 in the stage 1A to 63 in stage 4. Similarly, in score 2, it declined from 99 in stage 1A to 66 in stage 4. The endometrial cancer individualized scoring system showed excellent prognostic accuracy, significantly outperforming the Vigo staging. The area under the curve was 0.87 for score 1 and 0.88 for score 2 in predicting the primary outcome, compared to 0.69 for Vigo staging, and there was a significant difference in the performance, which is shown by the p-value. The ECISS also maintained strong performance within individualized Vigo staging, which means that within the same stage of Vigo, you can see different performances and different scores of the ECISS, which are highly reflective of the prognosis, despite the fact that the cohort of patients have the same stage according to the Vigo. So means that the scoring system is more reflective of the prognosis compared to the Vigo staging. So as we mentioned, ECISS has an excellent prognostic accuracy in terms of the area under the curve, and it maintains very high performance compared to the Vigo staging. If we compare the ROC curves, we can see how the performance is quite different, as seen in figure 3. In terms of Kaplan-Meier survival curves, they confirmed the superior performance of the ECISS. The survival probabilities were clearly separated across the ECISS scoring groups, with minimal overlap between confidence intervals. This reinforces how the ECISS rule in refining prognostic stratification beyond the anatomical staging that has been standardly used for years. So this study validated the endometrial cancer individualized scoring system across 5 European centers, confirming its strong prognostic performance and clinical value. Both ECISS scores, 1 and 2, calculated at the diagnosis and with the treatment planning. So with a score 2, you can use different treatment options to see which one is yielding the best prognosis. So they both demonstrated significantly higher accuracy in predicting the 5-year disease-specific survival compared to a Vigo staging. Importantly, ECISS was able to stratify risk even within the same Vigo stages. highlighting its potential to guide more personalized treatment decisions, unlike the Vigo system, which focuses on the anatomical factors. These findings align with a growing body of research supporting the use of machine learning in gynecological oncology, while recent updates to the Vigo staging system attempt to incorporate more prognostic factors. ECISS offer a more streamlined and adaptable solution, especially in the setting where molecular testing is limited. So obviously, we can see that ECISS demonstrated strong prognostic accuracy and consistent performance across diverse European populations by offering refined risk stratification and treatment guidance. And it presents a promising tool for advancing personalized care in endometrial cancer. Of course, broader validation and integration into clinical pathways are recommended for widespread adoption. Thank you so much.